Hello, hi everyone. We're just getting started here. We're just going to wait a few minutes as people are still joining. Thanks so much for joining us. Again, this is our Shift Happens webinar hosted by Global Health Corps, and we'll be talking about contraception access today. So we're just getting started. Just welcome. Please do go ahead and turn on your video if you're able. We'll ask everybody to stay muted for now. We just have folks joining, so we'll get started in just a few minutes. All right, if you can see the chat from where you're calling in, we'd just like to have everybody who's joined so far to just go ahead and share your name and your affiliation if you'd like, and also where in the world you're joining us from. Just tell us where you're calling in from right now, as we're just waiting a few minutes for folks to join. Can I ask our speakers to actually go ahead and be the first ones? Just say where you're. We have Nico. Just say where you are and where you're calling in from. Oh, we have Nico from World Bank, currently in London. Charlotte Tweedley. Hi, Charlotte. Charlotte's calling in from Empower, and she's in NYC. Awesome. Okay, I know we have our speakers on. We have Noreen from IPAS and from North Carolina. Thanks for joining. All right, so for everybody who's just still signing in, we're just waiting a couple of minutes to let folks join. Welcome everyone. Thank you so much for joining this webinar hosted by Global Health Corps. We're excited to talk contraception access today. If you're just joining, please do go ahead and share in the chat your name and your affiliation and where you're calling in from. And we will kick off in just a couple of minutes. Okay, we have Liz calling in from San Antonio. We have Lenice from Friends of the Global Fight calling from DC. We have Jenny James from Kampala with Max CHS in Uganda. Welcome. Can we have our speakers and our moderator please go ahead and put in the chat your affiliation and where you're joining from? Have Amelia calling in from Tahoe, California with Preston Warner Ventures. Welcome. Temple from Packard calling also from California. Nice way to start your day. Hopefully not too early for you guys. We have Heather. Hi, Heather, joining us from GHC from New York. Tony, a current fellow from Malawi, later in your day there, calling from African Institute for Development. Right, awesome. So I think we'll go ahead and get started. Chantal, if I can just ask you to turn on your video if you're able. I'd love to just go ahead and introduce our speakers and our moderator. All right, so first I'm just going to introduce myself briefly. My name is Brittany Cesarini. I work on communications and advocacy with Global Health Corps. I'm real excited to be here today. We have been working to coordinate this conversation for some time on the really important issue of contraception access, how it's being impacted during COVID, and how we can also protect it, during the pandemic, as well as expand access beyond this really challenging time. So I will not talk very much. I will just be turning it over to Heather Anderson, who is the CEO of Global Health Corps. She will be moderating our conversation today. And she's going to just give us some intro remarks, and then she will introduce our wonderful speakers. All right, Heather, it's all yours.
Wonderful. Thank you so much, Brittany, and good morning, afternoon, evening to everyone. Thank you so much for joining today. It's great to be here to discuss a topic that is fundamental to achieving health equity, protecting the right to decide when or how or if to have children. Around the world, as many of you know, an estimated 50% of all pregnancies are unintended, which reflects a significant unmet need for contraception. Data points to some widespread global trends: more time spent single and sexually active, a desire for smaller families, and later entry into parenthood. Data also shows that some populations are particularly impacted, including adolescents, migrants and refugees, and postpartum women. We know, too, that gender inequality affects contraceptive access and use in many ways. These include power imbalances in relationships, sexual violence, and limitations on personal freedoms. Many of these constraints have been both illuminated and heightened during COVID-19. Government lockdowns, physical distancing policies, and economic pressure have all driven up rates of sexual violence and unwanted pregnancies and hindered access to contraception, including safe abortion. But that's not the whole story. In all of its horror and heartbreak that we've been seeing, the pandemic is also an opening to consider what wasn't working and to build back better, or to reimagine anew. And that for contraception access, there is push to use a broader, integrated concept of sexual and reproductive health as a framework for policy and practice. This profound shift, though, will only be enacted by leaders who deeply understand systems, are relentlessly committed to equity, and take a people-centric approach to global health. And so as such, today I am thrilled to introduce you to three such leaders and advocates that are here. Please join me in first welcoming from Uganda, Tina Nabwire, who's a knowledge management specialist at African Women's Development Fund, co-founder of Kokoi Stories, and excited to share a 2015-16 Global Health Corps alum who spent her fellowship year at Marie Stopes International. And then joining us from France, we have Jeanne Heffes, who's a senior policy and advocacy advisor at IPAS. She is a 2016-17 Global Health Corps fellow who worked at Planned Parenthood Federation of America. And lastly, but surely not least, we have joining us from Rwanda, Chantal Umahoza, who's the executive director at Spectra, which is a Rwanda-based young feminist activist organization. So thanks to all you amazing women for joining us today. So to kick things off, I would first love to hear from each of you in just a sentence or two why you're spending your days, and I'm guessing probably your nights, fighting for contraception access. What's your personal connection to this issue? Dina, let's hear from you first.
Yeah, thank you, Heather, and thanks everybody. So as an African feminist, the issue around contraception access is it's something close to my heart. So it's both political and personal, but it ties into the bigger discussion around body and health rights for women and girls. So looking at politics of control over women's bodies, and growing up as a young girl between rural Uganda and in parts of the city in Kampala, I've experienced individual control, but also control from community members, from family members, and even at state level when it comes to choice for women and girls. And so issues around sexual and reproductive health then become, they're really very pertinent in the sense that they border with human rights. So if we want to continue to look at women as full human beings, then their body rights are a part of that. So that's how it gets personal for me, and it motivates me. I know friends, I know family members who have really been denied access, and I believe that moving forward, it's something worth fighting for, that women and girls are able to choose. They're able to determine when to have a child, with whom to have this child, spacing of their children, and that's very pertinent. So yeah, that keeps me awake, Heather. Thank you.
Thanks, Tina, for that. Chantal, how about from you?
Thank you very much, Shida. And just like Dina, I think I also like to build up on that to say that uh, coming from the feminist, narrative or statement that personal is political, is to say that what happens with the woman's body or with an individual is political. And so, and to make it even more stronger for me, I always say, and I always find that sexuality is central to any other human, issues, human rights issues, or even other activities or issues that we talk about. If you look at sexuality as a whole, and here specifically, if we talk about bodily autonomy, as in the right to access how one controls their body, it is linked to issues around economic justice. It is linked to issues around ecological justice, that we cannot talk about access to contraception or women's bodily autonomy in vacuum of the country's economies, of the ecological justice issues that we talk about, because these are very interconnected issues. And so it really keeps me at night, because I really find that to be really essential. And without one's right and autonomy to decide how they want to live their lives, how they want to space their children, whether they want to have the children or not, I find it to be really central in everything we discuss about development and politics in general.
Mm-hmm. Great, thanks, Chantal. Really highlighting importance of autonomy, as well as thinking about the intersectionality around specifically this issue. Jen, from you, please.
I'm not sure I'm going to add much. Perhaps I should say my uterus. But more seriously, I think advocates, we come into this work, this social justice work, because of personal experiences of violence or a deep sense of injustice, whether it's felt at a personal, a structural, or societal level. For me, a woman's decision to carry a pregnancy to term is one of the most important and sacred decisions in her life. And forcing a woman to carry an unwanted pregnancy is an unbearable human rights violation. And it's one that I have the deep honor to work on every day at IPAS. And so abortion is a gender justice issue. At its core, it's an issue of justice, of equity. For me, it's a non-negotiable and integral part of SRHR. It should have been in the title of this webinar too. It's constitutive to our basic democratic freedom, our collective right to life, to health, to self-determination. I do a lot of research on very active anti-SRHR, anti-LGBT groups as part of my work at IPAS. And so yes, I can't sleep at night knowing that there are legislators and outdated criminal justice systems in place and actors that devise very creative, old and new ways to regulate and control our bodily autonomy, whether it's our sexuality, our gender identity, our sexual preferences, or our fundamental choices over our reproductive future.
Mm-hmm. Great. Thanks, Jen, and thanks to the three of you. And so now, as we're talking about and living, all of us, in COVID-19, it poses new significant challenges to ensuring that women can safely and affordably access safe contraception around the world. This is true everywhere, but especially so, as you all know, and where resources are limited. Dina, COVID-19, restrictive interaction measures in Uganda saw you locked down in your home village. Can you tell us about the situation around access to the pandemic, since it got underway? How has supply-demand been affected, resource constraints, disruptions to supply chains? I think myself and everyone on the line would love to really sort of hear what has this firsthand experience looked like in the pandemic.
Yeah, thank you, Heather. And there was, I think the bigger way to look at it was uncertainty. In terms of, so there was supply in some of the health centers, so supply of commodities, and they had commodities on shelves, yeah? But then when restrictions set in, it became very unclear. While there was demand, people could not access. They needed the service, but they could not access services. So, so that was part of one of the cases, but there were also cases where we had stockouts, and just tying into some of the statistics we had, so about 50 health facilities within my whole county never had, they ran out of stock. And I think the other way to look at it is nationally in Uganda, so you have about 65% of sexual and reproductive health services being actively delivered by non-profits and 35% by the government. And so in the face of bans on private vehicles, and so then it just affected supply in majority of the health centers. But we also saw a drop in options for women. So there were cases of, yeah, this is what's available, so this is what I'll end up using. And that meant that women could not consistently use some of the methods that they were using initially, and they had to quickly, make switches. But also something interesting that we observed was around an increase in sort of wishing that more women could actually access long-term acting methods as compared to short-term in the face of a pandemic. And I think as activists, this speaks to we might want to focus on term acting methods. So it was an issue of mixed picture, but also in March. So nationally, between March and April, we had very drastic like a fall so a reduction in uptake, yeah, and that was by about 5% nationally. And I think what's important to note here is majority of this was among young people. So the difference was about 20,000 people falling off the uptake numbers. So, and of the 20%, so 25 of them are under 15. So I think that's really important for us to note. So just tying what was happening in my village to what was happening at national level, and just emphasizing that I think that it gave us quite a lot to reflect. And as we discuss, hopefully we can talk about some of the innovations and ways in which the government and other actors were able to sustain supply, but also be able to tap into the demand that was coming out of communities. Yeah, thanks.
Great. Thanks for sharing that, very specific perspective of what you've experienced and seeing. Chantal, in Rwanda, a lot of the focus on late has been around shifting legislation to protect the rights of adolescents with regards to access to contraception. I'm curious to hear, how has COVID impacted your advocacy efforts in that realm?
Yeah, thanks, Heather. So honestly, pre-COVID realities in terms of access to contraception in general in Rwanda wasn't a perfect picture. There are different issues that we have been working on, even though we know and we do recognize that there is a lot of progress that has been made. But there are different critical areas that needed advocacy that we are working on together with the Global Corps Alliance and Alumni here in Rwanda. Specifically, we're looking at how there are still restrictions in the legal context when it comes to access to contraception for young people below 18. At the same time, the hot topic in the country is the increasing rates of teenage pregnancies, which is more prevalent among between 15 and 19-year-olds in Rwanda. And so we have a law that forbids young people in general to access contraception or health services in general, apart from HIV treatment, if you're below 18, and it requires that there has to be authorization from a parent or a guardian. So now, regarding, if you look at a context that is very, that is where sexuality is still very taboo, you would say, not only in policies, but in service provision in communities, for anyone below 18 to get permission from their parent or guardian to access, that is a very big barrier that is not going to, that rarely happens because there is no conversation going on between parents and children to start with. And so we were working different network to see how we can contribute to the discussion to this. At the same time, we also had restrictions around, we still have restrictions around access. It's not restrictions, but it's non-regulations of the pharmaceutical companies when it comes to provision of emergency contraception. As of today, emergency contraception is still like sold at a very high price, only unregulated and only available in private pharmacies. And this has also impacted how young people can be able to use this form of contraception. And so, and then COVID came in. Obviously, it became a priority in the health sector, not only in Rwanda, but worldwide. The shift in attention, in priorities and resources went to COVID. Even civil society organizations, when it came to resuming some of the activities, the encouragement and the motivation was to respond to immediate and emergent issues around people suffering, people needing basic needs. And so advocacy for these legal reforms came to a standstill. And also we spent more than 2 months where civil society organizations could not gather and meet. And that to some extent impacted organizing, continuing the discussions that we had already started towards the end of last year. And definitely we're slowly resuming, and we hope now that things are starting to, there's still a lot of work, and we feel like now the health sector is getting some sort of relief because we feel like Rwanda has also managed well the pandemic, and we feel like very soon we can be able to get the attention of decision makers to once again to come to this discussion about provision of these legal restrictions and how we can really make sure that access to contraception is not a privilege, like the title of this webinar.
Mm-hmm. Thanks, Chantal. And Jeanne, in your work on global policy, you have your finger on the pulse of the global discourse, and institutions are framing and enabling access to the entire spectrum of contraception, including, say, abortion. And so I'm curious to hear sort of what impact, positive or negative, are you witnessing at this level?
Sure. So I'll start with the most negative first, and that's a real pushback in an attempt to manipulate the COVID crisis to define access to safe abortion as an elective, a non-urgent, a non-essential service, or to just ban services altogether. So we're seeing politicians who are advocating for the closure of abortion clinics claim that their goal is to increase the availability of medical staff or personal protective equipment. And we're seeing this in the United States, for example, where restrictions to abortion are being embedded into the COVID-19 response, but also in places like Slovakia or Poland. And this is really evident at a macro sort of discourse level, with efforts by the United States to even further stigmatize sexual and reproductive health and rights and use abortion and SRHR as an excuse to defund multilateral bodies like the WHO, which has devastating consequences politically, normatively, but also financially, right, on our global health system. And we saw that very clearly when USAID Acting Director John Bossa sent a letter to the UN Secretary General asking them to remove all references to sexual and reproductive health and rights into the global humanitarian response. On top of that, across the board, we're seeing the crisis used as an excuse to clamp down on basic fundamental rights and freedom, with increased executive powers being seized, militarization and police abuses going unreported. And we're seeing state failure to protect women's basic rights to movement, to accurate health information, and ultimately to healthcare in times of need. So, for me, the COVID it's a triple threat. It's the virus itself, it's the economic consequences of lockdown, and then it's the state repression using force to enforce it and preventing people from accessing services. That being said, since the beginning of the crisis, I would say that across sectors and institutions, the collective sense of advocacy and urgency hasn't stopped for one single second, and we have seen remarkable government actions sort of step in with support from the WHO, which came out on June 1st with guidelines that recognize SRHR, including access to safe abortion, as an essential healthcare, with these governments really making huge legal allowance for alternative pathways to healthcare for abortion and contraception by expanding access to telemedicine. And so we're seeing an increase in pharmacy-based access that minimize women's presence in overburdened and crowded hospitals. We've seen this in France, in the UK, but also in places like Nepal, in Pakistan, in Nigeria, in DRC, with an increasing recognition that women can have abortions by themselves, provided that they have the accurate information.
Great, thanks, Jen. So, sort of sharing out what the three of you are sharing and saying is that, we're hearing about rapidly evolving dynamics, huge shifts in public attention and resources, abundance of fear and uncertainty, and yet everywhere that leaders are rising up, that they haven't missed a beat and moving forward. So, thinking about and sort of what you're seeing and hearing and probably doing, what are the innovations that activists and advocates are pursuing to propel things forward, even during this time in COVID, but also in a post-COVID world where women can more safely access contraception? Chantal, why don't you start with that? We'll mix it up a little bit.
Okay. Thank you. So I think at the top of my mind and sharing from our recent experiences, maybe I can share about 4 different ways how we're trying to go about this. And, at the beginning of the whole COVID crisis, the whole narrative that we are going to only be providing essential health services or essential services, the whole narrative of some services being essential and others not being essential was like everywhere. And that's where like some of us were like, wait a minute, access to contraception is essential. Sexual and reproductive health are essential. We cannot single out COVID now. We also have to, like I said at the beginning, make these interlinkages about what happens if a woman cannot access to contraception during this time. What are other health risks are they going to be exposed to, and how does that even make it worse for her to be exposed, for example, to COVID? Basically making those conversations. And so some of the different ways, because obviously we were under total lockdown, was to use social media to and contribute to the whole narrative that SRHR, or sexual and reproductive health and rights, is essential. And therefore, if there were any plans from the government side to facilitate transport, because remember also in some contexts like Rwanda, transport at the beginning was shut down to public transport. And so we're like, if people have to go to access sexual and reproductive health and rights, these are also essential services that need to be facilitated. And also beyond that, recognize that if somebody has to go to get a health service, police or other government institutions that were already in place enforcing the COVID measures, they should be able to understand that this is also an essential service that needs to be provided at that time. And so we contributed to that through social media. Other ways was how I think more recently we have contributed to different media articles, one specifically to ask for resuming of the discussion on access to contraception among under 18s. And this was through a coordinated approach with different activists that were able to write this media article and put it out there and say, look, before this whole COVID came, we're having this discussion, we need to resume this because we cannot continue to claim and talk about teenage pregnancies. At the same time, we have laws that, are continuing to be a barrier for access. And then recently, in this month, in Rwanda, in the women's rights movement, we did celebrate the 17th anniversary of Maputo Protocol, the African Women's Rights Protocol. And from our side as Spectra, we made it very intentional that discussions around access to contraception was streamed in the discussions, and specifically those issues that still hinder access for under 18s, but also other cost-related issues, that are still there in the health sector. So we raised and we made sure that Maputo, as we celebrate Maputo as a whole, but let's also remember the key barriers in terms of access to contraception that is still a barrier here in Rwanda. And lastly, we just launched a very small, we call it the SRHR Fund at Spectra, and this specifically goes to direct support women that may need an SRHR service, but may not be able to get it due to transport barriers, due to other different issues. Some of the few cases we have been helping so far, one of them include a woman that needed to have her tubes tied, tubal litigation, and the nearest health center and the hospital where she could get that is Catholic. And this is also one of the challenges in Rwanda, that we also have a very big number of health facilities in Rwanda that are Catholic. And they are the first ones where women and girls can access for services, but they do not provide services. And so she had to be referred somewhere else, but she did not have the means to go there. So this fund, for example, identifies these cases and directly supports them by paying the transport, by paying the cost of the service. But this is not just support them directly, but it's also to use this kind of cases as basis for advocacy, as basis to show what a student that every woman can have access. Thank you.
Thanks, Chantal. So fascinating to hear, especially through your work at Spectra, both to pushing early on that, sexual and reproductive health are essential services, and what does that need to look like, recognizing the sort of the push through the media, and then seeing the impact of COVID, particularly around accessing services, getting creative to be able to help women. So awesome. Dina or Jen, either things you guys want to add sort of on the innovation front? Dina, I see you nodding your head. Why don't you jump in?
Yeah, thank you. And I think related quite a bit to the situation in Rwanda, and thank you, Chantal, for sharing. I think we've seen quite a rise in what I would call teleservices. So really transforming some of the everyday elements that we have. So in Kampala here, we have what we call boda bodas, yeah? And so boda bodas are really bikes that go around doing all sorts of things, transporting people. And these were transformed into an opportunity to extend services at community level. And in places like my village, village health team members were doing this on bicycles and sort of going out to the health centers to pick supplies and connecting those to women in communities, and I thought that was really great. But overall, I think there was also what we'd call a bold move towards self-help services, where even using mobile phones, more women calling in and just press this and you get this kind of information. So there's been an increase in uptake of those kinds of innovations. And I'm saying an increase because without the pandemic, such services have existed, so championed by some of the known sexual and reproductive health organizations like UNFPA, like PSI, but in terms of uptake. And I think the whole new normal, so the digital transition, has started, taking trend even in rural areas. And I think the mobile phone is going to be a very important aspect of delivering reproductive health services in communities. And I think for us, what we also saw at national level that's working is really the push to start acting based on data. Specifically, so at the beginning of the pandemic, and I think Chantal shared a similar experience around messaging on COVID that really didn't focus on any other issues that are actually very intersectional, and they do increase vulnerability for certain groups of people. So leaving out SRHR and other development issues. And so we started getting statistics coming in different working groups. We knew that maybe 400 people by the end of March, 400 women was registered to have experienced at least one form of gender-based violence. So a lot of statistics were coming in at national level, and we saw action led by the government and other key stakeholders to sort of act in this. And at the moment, at that time, we got national guidelines on sexual and reproductive health during COVID, which I think was really a great step based on the data, but also more coordination working groups producing data and sort of highlighting best practices. So I think there's been increase in coordination. And you can imagine, so in a moment where people are not going to move into meeting rooms and pull this off, but so you can imagine how quickly they were able to pull off all of this using mobile phones, using teleconferences and etc. So I think for me, that was really great. At rural level, like I talked about the village health teams. So these are really para-providers, so out of the Ministry of Health. And I think that they were really handy, and it's an opportunity to continue expanding them. I think what I loved to have seen in there was expanding the village health team members beyond just the formal structure to start including people like the Mothers Union. And Chantal has rightly talked about the social cultural norms that shape access and uptake of reproductive health. And Mothers Union are out of the church structure. And these are very influential when it comes to what women and girls do, and even the men. So it's really important that the structures are there, and with the guidelines, it became easier and even clearer, because at the beginning of the lockdown, the village health team members weren't very sure what to do, you know. But with the guidelines, it became clear you can actually go talk about COVID and also talk about sexual and reproductive health rights access. So yeah, that's what I can speak about now.
Thanks, Dina. And Jen, I'm sure you have things to add. I want to get to Q&A with our participants, but I want to do first a quick lightning round with the three of you. So very brief. Let's say we're able to get the heads of states or ministers of health listening to this conversation. What is the one action you would want them to take to expand access to contraception? Chantal.
I would say that it's really, really hard for me to say one.
I know. Just so many
but
things.
I mean, I think, yes, we can talk about revision of laws and all that, but as long as there's no actual implementation in a way that is coordinated and, you know, well funded, we're always going to have those restrictions. So the one thing that I really want to ask is that there should be a deep analysis of the structure here, including economic and systemic barriers that are still hindering access to all forms of contraceptions. And then the government should take should take it seriously and invest into addressing these barriers. This could be around religious restrictions. This could be around you know, the laws, but also you know, affordability, or other costs that come with relation to having the access to contraception, like I've talked about transport, for example. And these need to be addressed. If they cannot be addressed, the full realization of these services and these rights will continue to be a challenge.
Thank you. Dina, what's your ask?
So my ask is around, we have data, and I think this is both in Uganda and globally. We are at a time where we are really working with evidence. And I think for me, the step is that transition from data to action, in the sense that our governments, and especially in Uganda, we have to start looking at it comprehensively. We know that 10% of all maternal deaths associated with unsafe abortions, and we can be religious, we can be socioculturally, all of these things, but this is the data. And I think it's time that we wake up to the evidence that we have. And in instances where we have utilized this data, we've seen that it's working. I've just talked about some of the things that we are doing. And so for me, it's a call to sort of work around messaging of sexual and reproductive health based on the evidence that we have. If we are talking about a drop in access to services, and we are saying 25% of all of that, and this is Ministry of Health data, are young people, and these are young people in secondary school, and then our laws are actually sort of, you know, mismatching with the data. So if you ask me, with the current situation, we are making steps forward. So if you move 10 steps forward and then move 15 steps backwards, so you're moving, but you know, in directions that you struggle to track yourself. So I really think that it's important, and I think also data has showed us, for instance, that if we invested even in other broader aspects of sexual and reproductive health, such as preventing or ending child marriage, at least for Uganda, we're going to, the country, first of all, loses about $5 million US, you know, in child marriage costs. And I think for me, this is important because, like Chantal mentioned, all of these issues are not in a vacuum. They are related to socioeconomic implications, and we are losing money, and we need to look at this data to be able to save taxpayers money in this country. Thank you.
Yeah, great. Jeanne.
Yes, and building onto that, I would say an ask would be that the response to the crisis be rooted in human rights and be gender specific, and that it doesn't just respond to the immediate impact of COVID-19, but builds stronger health and social protection systems, acknowledging that these are fundamentally political and financial decisions and about designing sustainable systems for the well-being of the majority and protecting healthcare providers and care work, both paid and unpaid. When it comes to sexual and reproductive health and rights, I would say very bluntly, just overturn all discriminatory laws that infringe and criminalize bodily autonomy and freedom, including gender identity and sexual orientation, access to sexual and reproductive health services, including abortion and abortion self-care, and then maintaining sexual and reproductive health services, including comprehensive abortion care, post-abortion care, and access to contraception as essential services during and after the crisis. Sorry if I'm repeating myself.
You're not, but thank you to all three of you. I mean, I like to do this work at Global Health Corps because all of you inspire me, and for the work that we are doing, training and mobilizing leaders that are committed in this work. So thank you for all of that. Why don't we turn it over now to the audience and open up for opportunity to ask questions, share reflections. Please turn on your video and unmute yourself. You're welcome to just sort of wave your hand and start speaking. You also are welcome to enter into the chat box. If you have a question, you're welcome to do that too. So, so what are your questions for our amazing panelists? Yes, and please don't forget to unmute yourself. Something that happens to all of us.
Hi, everyone. My name is MJ, and I just want to thank you all for being here today. The question that came to mind was, where are you guys drawing strength and inspiration from these days? I know it's like a very difficult time for everyone, but where you're drawing your inspiration and how you stay motivated in your work.
Panelists, you can just jump in. Feel free to respond.
I'll jump in. I draw my inspiration from, just to highlight that my work involves quite a lot of documentation, so documentation of experiences of women and girls. And so I draw my inspiration from the levels of resilience that I have encountered through profiling the voices of women and girls, and levels of resilience. Even when I talk about unsafe abortion, I have seen women who have stood the ground and made clear the fact that this is their right, and they can demand a service, and they'll go out of their way to make sure that they're accessing a service, but they are going to help other women. So I'm speaking about the activists. So those inspire me in the sense that they've sustained energy. There's quite a lot of challenges, and as I think Jane mentioned, there's quite a lot of issues around policy and regulation when it comes to sexual and reproductive health, and just seeing all of these women standing up and keeping their fists up for these rights, that really gives me inspiration. Yeah.
I would maybe just like to ask as a follow-up, especially to your answer, Dina, is then, like, what's the role for men?
What's the what? Hi, Heather.
Looks like Heather's frozen.
Apologies, you guys. I think that was internet on my end. Now I'm back. I was just asking, or maybe just like dropping the mic to be saying, what's the role of men? Dina, you talked about women standing up in solidarity. what do you see, whether in this time of COVID or what we want in the future? What is the role of men? How can they be working to further advocate, move things forward, address what's happening now?
Yeah, so that's really a great question, Heather. And I think it's important to look at it broadly. So starting with men as consumers. So men do need sexual and reproductive health services. And I think it's a great question because, thank you for the prompt, Heather, in the seeing ourselves to sort of shift the responsibility and in our way of messaging, so making sexual and reproductive health an issue for the women alone. And so I think that men, as we continue to repackage the message, to bring more men into realizing that they too need the service. So if we are not speaking and raising our fists for this, it's going to affect them too. But also the responsibility. And as I mentioned earlier on, growing up in my village, individual men walking up to you and, so sometimes you have men as on the other side of the trajectory. So either as perpetrators or really bystanders that are not active. And I think it's really important that men start to personalize this issue. And we started off by saying it's both political and personal. And I think it's important that they stop looking at this woman who is being denied the service as that other woman, but to connect that this woman is a sister, is a mother, is a friend, and so it gets home, So at the end of the day, I think it's really important that we share the responsibility and encourage more men. And this is being done by several partners, and I think it's really the way to go, especially the aspect of men consuming sexual and reproductive health services. Thank you.
Mm-hmm. Thanks, Sina. We've got a question in the chat box, and then Amelia, we can move on to what your question is. So first from James, asking, why are there no government-led mass media campaigns on SRHR, mostly in developing countries? So I guess the question is that what you're seeing too, or other thoughts behind it? What do they look like?
I can say a few words. I think there are campaigns. There are strong SRHR and family planning campaigns in a lot of the countries where I've worked or that I've seen. I would say that safe abortion sensitization and access to abortion, or advocacy or strong forward-facing messaging around abortion are rarer in contexts where abortion is heavily criminalized, but that otherwise you have sort of private-public initiatives for access to SRHR, or even privately funded campaigns by organizations like DKT, who do social marketing around access to condoms and contraceptives. They might not be rooted in a strong rights-based discourse, but I think in some countries or in developing countries, like you're right, James, there are strong government-led initiatives for access to family planning and contraceptives. That's my take on it.
Thanks, Jen. Amelia, do you want to share your question?
Sure, thanks. I didn't write it in the chat box because I'm kind of still forming it in my head, but I'll share anyway. I've been thinking a lot about how we, kind of the world, does quote unquote development work or humanitarian work, and a lot of those conversations have been an outgrowth of the kind of social justice simmering to the surface issues that are happening, especially in the United States right now. And so I'm really thinking about kind of what that means for quote unquote kind of localization, or really how we work with kind of local organizations and local actors on the ground. And so maybe my question is for Jen, working for IPASS, but also I guess something for all of us to kind of question or reflect on, especially when we're talking about the advocacy to overturn certain laws that might be really based on a country's religion or a culture, or how do we, especially if we're coming from outside and we're not kind of a local in that country, how do we kind of do that thoughtfully, tactfully? How do we kind of work with local actors to ensure that those, the laws are really grounded and kind of what's right for the people in that place? I'm not sure if that makes sense, but that's kind of how it's coming to me right now.
Thanks, Amelia. And maybe, I don't mean to interrupt, but maybe, Jeanne, there's your perspective, but for Dina and Chantal, in the countries where you're working to think about legislation and policy, I almost would be interested really to hear your thoughts of how outside actors can be engaging to help move forward the policies and reforms that you want to see.
Yeah, thanks, Heather. Absolutely. And I would add, what kind of outside influence do you really appreciate, and what kind you're like, oh goodness, if they could stop doing this, that would be really helpful.
Well,
yeah, I mean, I can. Oh, no, go ahead.
All right. Okay. I can share just briefly from the Rwandan context, but also from the feminist perspective, to just say, like, anyway, I cannot speak for the rest of the countries, but like the restrictive abortion laws, for example, that we have or we've had in Rwanda, they are colonial laws. They are not cultural. They were not put together coming from the Rwandan culture. They were imposed during the colonial era, and they were reinforced over time through religious, influences and all that. And so they've, over years, they were embraced and, integrated into what people call now, this is our culture. But if you go way back, this is not so much of like a culture thing that we already had in our systems of like, having to punish women like that, or having to think that it's okay to take women to prison for exercising their right to bodily autonomy and all that. And so I obviously contexts vary, but in this context, we have also had now a government that is really pro women's rights, that have ratified different human rights instruments. And so when it comes to supporting the localized, it is very crucial that you first understand what is needed, yes. But at the same time, once a country signs and ratifies regional or international instruments, holding them accountable goes beyond just the context in that country, because these are also international agreements that other countries can also be held to. And so this kind of, it should come in form of, support and solidarity, understanding the context. But I don't think it should also be looked at as, I'm an outsider, I don't want to help. But it's to understand how can I help, but also understand that this is not something that is part and parcel, for example, of Rwandan culture. These restrictive social culture norms. We still have very targeted religious fundamentalist campaigns and like influences in terms of policies, in terms of women's bodily autonomy and rights, even as we speak today. And so, and these are external, external influences, not part of the Rwandan, context. And so, I think we need to analyze what we see as external and internal, where the influences and issues and restrictions coming from mostly. Are they coming from that specific context, or they are actually influenced by external factors? And then we start seeing them as part of that culture. Thank you.
Thanks, Chantal.
Thanks so much, Chantal. And that's, as Chantal knows, our work is transnational, and obviously there are historical and power imbalances that we try to address at all times, and that we must strive to do better at. But on the topic of the opposition and religious fundamentalism, there is a value in sharing knowledge and information and solidarity and strategy, because the groups that I track that are coming from Arizona, who are coming to Rwanda to attack legislation, have a very specific agenda and history that is anti-rights, that is anti-woman, and that goes beyond sort of colonial prescriptions or place or locality. And so we have to be acting as a consortium of organizations against these very globalized forces against us that really try to take heed at every step of advances for sexual and reproductive health and rights. And then when it comes to IPAS, more specifically, if I have to speak about my organization, IPAS has country offices where the staff are gynecologists and midwives that are from the countries in the places where we work, and our work is rooted in collaboration with coalitions of advocates and activists and feminists who are in country. And so, I don't think the intention is to go to a country and overturn a law, as Chantal was saying, but it's to rather draw the sort of historical origin of a law and the contradictions between public health policy and maternal mortality and what's being enacted. And so most of the people in the on the front line who are doing this work, whether they're at IPAS or not at IPAS, in consortium with us, are really from the countries where we work, if that makes the distinction here. And then it's about information sharing and disseminating of global technical and clinical guidelines that sort of inform our work collectively as a community of practice. I do think that there's a lot of work that we need to do in how we think of expertise around access to abortion and in centering women's voices, whether those women are from Arizona or Wisconsin or Uganda, and that the big effort that we have to do in terms of de-hierarchizing has to do with demedicalizing and the power of gynecologists, I think, in the medical sector across what we do. So I think that's another area that's extremely challenging, and that we have a lot to learn from the communities at large everywhere where we work.
Thanks. Dina, you want the last word on this, because we're going to need to wrap then. Go ahead.
Yeah, and so everything that Chantal and Jean have said, but just to add, I think something that has worked and continues to work in the feminist spaces is, and in research as well, which is what we call reflectivity. So being reflective at all times. And I think Amelia was really cognizant of this in her question, and just saying as outsiders. And I think the responses are really building on the solidarity, so that we do recognize that even when we are messaging and we say that no woman is free until all women are free, I think it's important as an activist or as a funder or as someone from another context going into another space to start to understand your own privileges, but also the power imbalances that shape whatever policy that we are looking at. And I think Chantal gave a very rich context to that, which I wouldn't repeat. But I think for me, continually asking you questions around who am I in this space, why am I here, it helps you. So when you are, for instance, in a national working group, then you know when to step back and let nationals, clarify things, take forward the agenda, and you know when to draw on opportunities to support. And I think Jean also talked about expertising. At what point do you actually recognize that you are not the expert, and the team that you're working with are the expert? And the moment we start to ask ourselves those questions, it's going to be easy. And I think solidarity has been talked about, but I think the other call with solidarity is you share the goal. So you're probably in a different context, but you share this goal. And it's what pushes you to continue to work with the different groups. Yeah.
Thank you, Dina. I think that's a lovely close on solidarity, reflection, humility, to be able to really drive this work forward. So I really want to, again, give a big thank you to all of our panelists. As a number of you know, before Global Health Corps, my career was predominantly in sexual and reproductive health. So these are one of my favorite topics for us to be talking about and navigating through. So thank you for everyone joining for the call today. I'm sorry we didn't get to all the questions. I have no doubt we could continue this conversation so much longer. For those of you that are in the GHC community, I would encourage you, if you are inspired by today's conversation, please write a post for Amplify. We'll also continue the conversation at our community portal. And for all of our other guests, thank you again for joining us. Look forward to finding ways of collaboration and engagement with you. So everyone, enjoy the rest of your day and hope to see you all soon, virtually or otherwise. So thanks, everyone. Take care. Bye-bye.